Produced by NWC.
QWorld, welcome to our next session podcast video. I'd like to thank you for your time visiting us, and hopefully we drive the experience and information that you need, as we try to do. Tonight I have some special guests. Amazing guys. I've worked with all of them in the past. The finest guys as far as just cardiology goes in this area in Springfield, Missouri, but at the same time, just good quality guys that really care about you as a patient and want to make sure that you guys get the right information from the right people. So I want to introduce my first partner to the left. This is Suntosh Parvathanehi, Dr. Parvathanehi. This is Dr. Robert Merritt, and this is Dr. Steve Khuen. They're all here just to give you guys a little insight on what it's like day to day from the cardiology standpoint, give you an idea of what their history is as far as why they got there, and then from there we're just going to give you a lot of detailed information about procedures and where things are going. So first of all, I'd like to welcome you guys. Thank you for coming. Really appreciate it.
Thank you. Thanks for having us.
These guys are on call. They're doing things all the time, seeing patients, have procedures. So for them to come out and hang out and just do this is very special. It's very rare as well. So it's a big deal for them. They care about you, obviously, as you guys know. So we want to make sure we give you great quality. So Dr. Parvathanehi, talk to us a little bit about you and your background and how you got started. Well, let's start with where you're from. Let's talk about where you're from and how you got to be where you are.
Sure. My name is Suntosh Parvathanehi, but I also go by the name Sunny. It's a lot easier, as you can tell. But I grew up in Chicago, born and raised. The family of two immigrant parents. They came from India and they traveled here in the 1960s when there was the doctor shortage at that time. And so my dad actually originally migrated over to Maryland and actually trained at Hopkins for not actually for general surgery, and then he eventually did CT surgery up at Mercy Hospital in Pittsburgh. And then he eventually migrated to Chicago, where he finally settled down there and raised my brother and sister, and then eventually me. So I'm from Chicago, born and raised, and always from Chicago.
I love it. Hey, Dr. Merritt?
Yeah, so I'm Rob Merritt, and I've been here in Springfield for about 20 years. I grew up in Dallas initially, and Kansas City. Have a little similar story to Suntosh. My mom was an immigrant from Europe, and so I'm first generation, and grew up in a little kind of blue-collar neighborhood, and got the opportunity to go to college, first one in the family, and it's been kind of a great road, and I've enjoyed everything that I've done. I trained at some of the really nice places, the Mayo Clinic and then St. Louis University, and I've been really lucky to be here and able to offer people what I can.
Yeah. All right, Dr. Khuen?
I'm Steve Khuen. I call St. Louis my home. I went to junior high and high school there. I actually went in the military after high school, in the Marine Corps for 6 years, and then it was then I decided I wanted to go into medicine. So I went to medical school, college, and then medical school after that. And trained between Columbia, Missouri and St. Louis, and then moved to Springfield about 11 years ago, and I've been here in Lebanon ever since.
Well, thank you guys. So the one question I'm sure everybody wants to know is why cardiology? So we got two cardiologists and one electrophysiologist, but why the path? Why? You got in, I know you love being in medical, you love helping people, giving back, making a difference, right? But why personally, from your backgrounds, did you choose to go in healthcare?
I guess I'll start. So mine was kind of a very unique story, I think. So I was injured in the Marine Corps, and I underwent several different surgeries. And through that experience, and one very daunting experience where it was thought that I had leukemia, I spent a lot of time in great concern over my own health, and it really just set a spin on my career goals, which were initially to go in the FBI. But after spending time with one particular nurse, actually, it really just woke me up to the idea of taking care of people, and that's how it started. So my initial plans were to go into nursing. Then I met with a physician assistant who told me about physician assistantship. And then he suggested, why don't you go to med school? I said, well, I don't have any money. I don't know anybody that has money. So I thought, I can't be a doctor. You have to have money or have parents that are doctors to go to med school. So he said, get loans. And then it literally clicked. And I said, that's what I'm going to do. I just kind of honed in to becoming a physician. But at that point, I really didn't know what I wanted to do. I just knew I wanted to do something. I thought about orthopedic surgery, obstetrics, I thought about general medicine, thought about ER medicine. I didn't really think that much about cardiology. that didn't really spark until after med school, and then it clicked one day when I did my first cardiology rotation. I was just hooked. So that's kind of generally how I got into cardiology. So.
As far as for me, what really triggered me was actually an experience I had as a child. Typically, I grew up in an Indian family, first generation family, and oftentimes you hear the mantra, be a doctor. And so, I was growing up in that situation, and both my brother and sister went to med school, and they're much older than I am, and so I thought, well, be a doctor. That's what we needed to do. But in the background, I wasn't sure if I really wanted to do it. And then in high school, I enjoyed my high school life. I worked hard, but I also played hard. I played sports and things like that, and actually played varsity tennis in high school and eventually traveled that to college. But there was an injury I had in high school when I was playing intramural basketball with my friends. I was 17, and what happened is I basically herniated a disc and found out I had a pars fracture of my L4. Apparently I was not born with an L5 like everybody else was. And so I have a pars fracture and herniated a disc from that. Basically the guy was boxing me out. And so I got thrown to the ground. And so after that incident, I really learned a lot because I actually had to relearn all the processes and how to walk. The spasm was so bad that it actually encompassed and inflamed my spinal cord.
Wow.
So eventually, with rehab and strong work, I was able to walk again and able to do all the activities I like to do and maintain a good quality of life. And that was really the spark that made me interested in really, for the first time, medicine. Because when I was a kid, I could just say, I'll tell you that my parents always told me to go into medicine. I'm like, whatever. Right. But that was really the spark that made an interest. And I was originally interested in neurology just because of the impact that situation had on me. But eventually I went to medical school, and then I learned different aspects about medicine. I really enjoyed physiology a lot, and so I actually enjoyed cardiac physiology. Throughout my medical school training, I enjoyed the interventions and all that stuff, and in residency, enjoyed learning about that. But what really caught my eye was an electrophysiologist known by Dr. Owen Bell at UT Southwestern, which is where I did my internal medicine training. And he really sparked my interest in EP because he felt the EKG is just one piece of the puzzle. And it's your job to look at that EKG and try to figure out everything else that's going on with that patient's heart. And so that really inspired me to pursue electrophysiology, which I eventually did at Vanderbilt University. So I'm here because of all those experiences, and those are the whys of what I do. So,
Thank you. Dr. Merritt.
Well, two guys that have had life experiences with injuries and recuperation and stuff like that. I really didn't have that. Kind of growing up in this neighborhood that I lived in, there wasn't a lot of upward mobility, I didn't think, and so my plan was to get out of high school and go get a job, right? So I had 2 or 3 jobs, and I got this one job at Merritt Laboratories because I had a background that I liked chemistry in high school, and I actually did well in chemistry and did well in physics and stuff like that. But then I said, well, hey, I'm going to just try and get this job, and it's kind of one of those upward mobility things where you feel like, God, can I move up? But there's sometimes you're in a situation where you feel like maybe you can't or something's holding you back. But I found out that I got the job. I interviewed 2 or 3 times for it, put in my application a couple of times. They finally granted me the job, right? So then I was in a chemistry lab where I was able to work with medications, right? Merritt Laboratories was owned by the guy that owned the Royals, right? Ewing Kaufman. And I went into their chemistry laboratory, and they had just, at that time, it was in the 1970s, right? They had just got the patent for cardizem, which is a huge drug, even to this day, is a mega drug, right? And it's never been really replaced as being the acute treatment for people with some arrhythmias. So we did all the basic science in terms of quality control on those drugs. And there were other drugs too, but that taught me that, hey, medicine can have an impact. And from that point, I just decided I'm going to drive my way and see if I can get into a higher research situation. Went to the University of Missouri and met a guy named Dr. Gerke. He had run the experiment station up in University of Missouri. Had the had a lot of connections with the nuclear laboratory there. One of the only reactors in the United States where you can tag medicines and do other things with that kind of research. Did a lot of that. And I, through Dr. Gerke, was just being kind of a mentor. He says, you kind of have the real drive to succeed in this field, and you should think about medicine. And so that was kind of that point that kind of uplifted me and said, okay, someone believes in you, you could really make it. And so it was really, it was a blessing. So I got to meet him, and then I've had other mentors in my life that have kind of helped me to understand, the role I can play in helping other people's lives. And so I found that to be really refreshing. It tends to renew me over and over, And so I really appreciated the time I've had.
That's awesome. That's awesome. So now that you guys give us a little background, which is very good. Thank you guys for sharing that. A lot of that I didn't even know. So, but talk to us a little bit about what is the difference between cardiology and electrophysiology.
So, cardiology really it's kind of a broad category. So, in today's world, there's actually more subspecialties within cardiology than there's ever been. When it first started, cardiology was just cardiology. Everyone did everything. So it's kind of like nowadays a general cardiologist is kind of mirroring what a primary care physician would do for general medicine in that particular subspecialty. But within cardiology, now you have people who specialize in non-invasive imaging. So they specialize in echocardiography, cardiac CTs, cardiac MRIs, cardiac PET scans, and they do their due diligence diagnosing rare and difficult diseases. But then you also have the bread and butter interventional cardiologists, like the two we have here. And basically what they do is they take care of the heart attacks. And without them, we wouldn't even have a division. So they're kind of the backbone of what we do. And they also go so far as to actually be able to repair or replace valves in a non-surgical way, just through an artery in the groin or a vein in the groin, or instead of open heart surgery. And so that's kind of what the other cardiologists do, and without them, EP wouldn't even survive. So electrophysiology, what that does in particular, it's a field that looks at rhythm disorders. And so we're looking at your palpitations, you're feeling fluttering in your chest, you're feeling your heart racing away with you, and things like that. And what we do is we try to get an EKG capture on some kind of rhythm strip, figure out what that rhythm is, and if we can't, we actually go one step further by doing invasive testing, where we actually try to trigger the rhythm, and if we can find it, then we actually use essentially a fancy soldering iron, cauterize it, and therefore to help reduce recurrences of these arrhythmias. And we actually do it in the assistance of 3D GPS mapping and all that stuff. And so we actually get the 3D geometry of the heart and all that. But and so that's some of the things that I do. And I also do things like devices. So if people have rhythm disorders, and in fact, instead of it's fast, it's slow. So people who need pacemakers, and that's what I also do. And then there's the other patients who are the sickest of the sick of what we have, or the people with the unfortunate cardiomyopathies, either meaning that your heart function is low in that it causes something called heart failure. And those are the sickest of the sick we have. And what we do is, after they've tried to tune them up with the medications and the interventions they can do, I put in things called defibrillators, which is one of the few life-saving things we have in medicine. And so what a defibrillator does is it prevents cardiac arrest. And so I kind of span the spectrum of a lot of the disease processes in cardiology, but none of that could be done without a general cardiologist or even an interventional cardiologist.
Yeah, so I guess Rob and I do pretty similar things. So we're interventional cardiologists and structural cardiologists. So interventional means you go up into the body, you take a wire, and you open up an artery typically. That's most of what we do. I'd say 90% of it, if not more, for the interventional side of things, including the legs and other places in the body, but mostly in the heart. especially one of the things that excited me the most about cardiology, which is also the most difficult because of call, is heart attacks. I mean, you have to be there within 30 minutes, try to get the artery open within an hour or thereabouts, and but it's exciting because you have someone severe pain at the verge of death, peeking over that into the great abyss, and you go there and you put a wire, you open the artery up, and they're pain-free within minutes. In fact, I've actually joked with patients and nurses sometimes saying, I kind of wish they had a lot more pain after the fact so they'd take it a little more seriously.
Right.
Because people oftentimes, we're all creatures of habit. We get back into our old habits.
Right.
People who smoke or are addicted and whatnot, they end up going back to that. And you almost wish they hurt more so that they would be more motivated to quit. But that's a big part of what we do. And then structurally, what that means, we're really referring to replacing valves or closing holes for the most part. Mm-hmm. At least that's for what I do, and I think mostly what Rob does as well. So aortic valve can be replaced, the mitral valve can be clipped and therefore repaired. We can close holes in the heart called ASDs or PFOs when those are needed to be closed. And it's just fun, it's good, and Sonny does it in a different way. He sees the result of the work of his mind and his hands, and that's his art, and our art is also seen, so you can see it with the arteries of the valve, and it's fairly instantaneous, which is fantastic. Some of the things, of course, are more painstaking and slow, but for the most part, I would say that's what's most exciting about it. Mostly what I sort of associate myself as being is when I call myself an interventional cardiologist.
You want to add anything?
Yeah, I think I agree with Steve. A lot of times where the crash and burn artists, I mean, they're coming in the middle of the night on a helicopter, they have no blood pressure, their heart may be fibrillating, we have to shock them, and we're the interventionists. That's why we're called interventional cardiology, is because we tend to rush to the scene, and we correct the problem immediately, and many times we get great satisfaction. And the patient obviously feels wonderful after you fix their artery when it's been closed for about 3 hours. They're having the worst pain in their life, so to speak, and it's very gratifying. And then as far as doing the other interventions, it's more in a controlled atmosphere. We have these elective cases that we bring in, and Sonny's used to this. We bring them in electively as an outpatient, put them in the hospital for a day, and we replace a heart valve, or we close a hole in their heart and they go home the next day. It's it's some things that we do now, it took weeks to do and get people through surgeries and things like that. So the field is evolving, and many times just as fast as we can think about a new treatment, they're coming out, right? Or a new device, or an improvement in an old device that makes it much better. Yeah, so it's been that's quite an evolution over. I think about the transistor and how it evolved. It seems like medicine's on the same track. It's faster and faster. Things are getting better, and I think there's a lot to be said about that. One thing that I always look back on, I'm a little older than these guys, and I guess you can tell them by a few gray hairs, but we now have the culmination of a lot of population studies that I think are really going to bear on patient health in the future. CV risk identifiers, and actually being able to tell a patient when they come in just by a few variables based on their age, their sex, their cholesterol levels, their blood pressure, their ethnicity.
Their
Things
genes,
can be.
their genetics. You can check
Check
the proteins in their cells, and even get some predictions from that.
That's right. You can actually have a patient come in, and you can give them a sheet of paper when they leave that says, here's your estimated 10-year risk of having a heart attack or stroke, and here's what you can do to modify that risk. Now, that wasn't available 15 years ago because the Framingham Heart Study had not been thoroughly evaluated. Some other studies that were kind of looking at risk factors that led to people's outcomes, and all the guidelines that people were trying to generate at the society levels, which we all belong to, right? The ACC, the electrophysiology societies, they are finally at the point where they're generating information that's pretty useful. And I think that's going to be another thing that people can benefit from.
Great information. So what I really want to hear, and I'm going to take it back a little bit, but I want to hear about, seriously, so what I want our viewers to know what it's like to actually, so just go back to the raw, like you guys decided, we know you decided to go into cardiology, but that's like 5% of it. Like you had to take the MCAT, like then you had to go to med school, and then you had to do your residencies. So talk about that, because I believe like we want them to understand, especially for all the followers that are interested in going to med school, right? What it's like to take the MCAT, and what would you guys suggest that route? Also, talk about what med school is like. I mean, do you sleep? How many hours you work? I mean, I think people need to understand a realistic view of what it really takes to get to where you guys are now. This is the glory side, the beautiful side of it, but it takes a lot of work and effort, and you know.
So I'll say, when I was in high school, I enjoyed life, but I also paid the price by doing that because I was an average student in an already academically excelling high school. So I went to Hinsdale Central High School in Hinsdale, Illinois, and a lot of those individuals and people there, they come in like honor students there. And so even though I graduated with a 4.6 out of 5.0, I was still 150 out of 300.
Wow.
So ranks matter in high school. Performance matters because that really can, and depending on your ACT or SAT score, whichever one you take. So my brother and sister both went to Northwestern University. I applied and they rejected my application almost immediately, just because I don't meet the numerics for it. And so I ended up going to Loyola University in Chicago. And so when I was there, I put my mind to it because I knew I wanted to get to med school. And while everybody else was partying and having a great time, I was working really hard during the semester. And so I graduated with a 3.98 out of 4.0 at Loyola University in the end. And all I remember is my teachers respected me so much that when I showed up for my final exams, they would send me home.
Wow.
Because there was no reason for me to take it. So if you work hard up front and don't get caught into the party culture and all that, and you can still have fun. I'm not saying you can't have fun. I had plenty of fun and good memories. But you know, when there's a goal in mind and a goal set, pay attention to that goal first, because you can't take that party culture with you out of college. And so that was the first thing I did. I actually buckled down and I studied. Once I got into medical school, I will say that the techniques and the skills I learned in how to study in college actually paid off. And so it's a lot of studying, it's a lot of rote memorization, and the exams are also written that way. But your question about the MCAT that when we took it is going to be a lot different than how that is now. They changed it about 2 years ago, and it's completely different. And so when we took it, we had a lot more basic science and a lot of verbal reasoning. The verbal reasoning were like old textbooks, and then you have the 3 dots. They're actually called ellipses, and you have the 3 dots, and then you have the conversation starting up in a whole different context, and then the question would be, so what happened in between? So it's and those kinds of questions are the what questions. So what they're doing is they're looking for your ability to create inference and your ability to deduce what's actually going on, and then also demonstrate what's your capability with science. And so, and then the new MCAT, I believe they also incorporated the essay portion, which I had during the time I took the MCAT, but then also they incorporated psychology. So mental health is an issue and it's being recognized. And so they want physicians that are able to do the whole picture, not just focus on one thing. And so, because remember, we're treating patients, not an organ. So, so I think that's what the MCAT's for. But getting back to the med school, yeah, I mean, I studied a lot, and I had fun too. But it's a different type of fun, because the people you're with are all going through the same boat. So there's a sense of camaraderie, and that carries with you into residency and all that. But my only advice is study hard, get into the best named institutions you can possible with the best training, because names matter long term.
Yeah, so I think I can echo that. You know, it's a lot of hard work to get the study profile down so you can manage the time and manage all the volume of information that you need. And you have to be fairly regimented and fairly understanding that there's going to be a lot demanded of you. It's not asked, it's really demanded, because there's a large volume of information that you just have to be able to kind of work your way through, understand, and then be able to not only just put it out on a test, but you're going to also have to go through an interview process where people, you know, really, they're looking for specific things and they're asking questions for a reason. And you have to be able to, you know, derive, at least from what you've had in your past experience, that gives them the feeling that you've got the heart for it, you know, not just because you're a cardiologist, but you have to have a strong will and a good heart, and you have to, you know, be meaningful in the way that you want to present yourself for this kind of profession, because it really is a profession that that is it's highly respected.
Right.
It's highly cherished and sought after by the community. The community really needs a lot of good physicians, and we have a lack of physicians right now still, and we need to incorporate people now that are at a totally different kind of level of learning. I think they have at their fingertips so much information right now that it's going to be a different technique of how to get to the answers. And there's going to be so many options of answers now. When I was in medical school, there was in residency, there were only a few answers.
Right.
And that's because we didn't have the depth of knowledge that we have right now. Well, I don't think there's any way that anybody can conquer the full depth of knowledge. So now what you have to do is understand how to get the knowledge, how to find it, how to harvest it, how to put it into use. And that's probably the same in a lot of other professions, but you're really expected to get it right. So you gotta figure out that methodology. Like I said, I had a lot of good experiences with a lot of mentors, and I think finding a good mentor is really a great idea. I have a daughter that's 22 years old right now. She's just finishing her her undergraduate education. She's a scientist, so to speak. She may or may not want to be a physician, but I think there's a good likelihood. But she's having to, like Sonny said, you have to establish a real foothold, and that has to be a very good grade point average in a good institution, and you have to have good referrals, and that's something you have to focus on.
I'll just kind of maybe add to it a little bit. Like I tell my kids, you have to pursue what you love and work for what you want. And so if you have to find out you really want it to be a physician, period. That's never going to change over time, I don't think, because it's a very long road, and it's a very wide road too. And what I mean by that, long road meaning, of course, a long amount of time, but you are constantly focusing on working and learning and attaining new skills and new pieces of knowledge and overcoming many obstacles, whether it be an MCAT test or a test in pre-med or a test in medical school, whatever the case may be. So you really just have to really want it, I believe, more than most things, to just be quite frank, because of that wide and long road. So you have to constantly work at it and seek help. And that's a big thing that a lot of kids, especially when I was going through, didn't want to do, is you want to just sort of hunker down and just bury yourself in the books and not seek out help, especially pre-med. Right. Seek out help. Go to teachers' assistants, go to your friends that are also excelling in class. And I would even say, like this, when I was in college, I said, I'm going to go sit in front of the class. Right. I went to college at 24 years old, and kids were in the back laughing and falling asleep and whatnot. I got to the front of the class, I paid attention, I leaned forward, took notes, asked the professor after class if they were available, questions that I may have had, and sought help with the TA if I was having difficulties. But you really just have to want it and accept that you're going to have some sort of, I won't call them failures, but some challenges that you're faced with. But seek help when you have those. It's a long road, and then getting to med school, that's the biggest challenge in the way I saw it, at least. But then you need to keep basically pushing forward so that you have the skills, the knowledge, and sort of the acumen and the sort of the name, if you will, if you want to do something that's competitive and challenging, and cardiology is competitive.
So I think what I'd love for everyone to hear is just a specific experience you had in med school, residency, because we know med school is different. Residency, you're actually active. Maybe more residency. Let's do more residency. A story that you really understood, like this is the real world, or the QWorld, as we would say, and something that woke you up, or an incident that said, I got to do better, or maybe work harder, or it woke you up, whatever it may case may be. Yeah.
All right, so I trained at the Mayo Clinic for residency, big hospital.
Yes, sir.
They had the longest halls that you could imagine for a hospital ward, right? It's just as far as you can see. And I was the resident on call, right? And I was on the cardiology service, right? But I was a resident. And the fellow wasn't there with me. He was at a different place, and so you could have 15 or 20 patients or more that you were responsible for the night of call. And I can just remember that first few nights I was on call, a particular patient that had not a good outcome, right?
Right.
She had come in with a heart attack, and she had had not a bad course during the hospital, but she had suffered through the heart attack and came into the hospital with some heart failure. Not severe heart failure, but significant heart failure. And then at about day 4, she was on the floor that night, and she had developed an arrhythmia, and I had given her some medication, right, to help with the arrhythmia. And then suddenly she just passed away.
Wow.
All right. And you know, at the Mayo Clinic, they had these lights down the hallways, and you could look at the lights, and they were the type of light would tell you what the urgency was.
Wow.
And I had just given this patient the medicine, and I went down the hall, and I was seeing some other, and I looked down the hallway, and this light was the bad light, right? Ran down there, and she couldn't be resuscitated.
Wow.
And I felt so paralyzed with, what am I going to tell my attending physician, right? And I called him up, and you know, and he was talking to me, and he says, you know, after everything you've told me, it's, you know, it's one of those experiences you'll never forget, because they had an acute cardiac rupture from the heart attack. Day 4, generally completed MI, had an acute rupture and died suddenly. And I thought it was something I had done, but it really wasn't. And that really just inspired me to, okay, I can understand life and some of the calamities that you get into, but that's probably what convinced me, even in that bad situation, that I wanted to be a heart doctor, right? That's kind of the night it seemed like to me that I said, I want to be a heart doctor.
I bet your attending made you feel like it was your fault.
I hope they did. No, he was nice to me.
That fool.
He was really nice.
I'll give just a very short story, but basically I was in my first, this was the month I decided I wanted to become a cardiologist, but it had nothing to do with this particular experience. But there was a lady that was was a guy, I guess, that was crashing with a complete heart block. It was 2 a.m, and we slept there. This is back in the day, I suppose they still do, where you sleep right there, you can hear the beeping in your bed. And the nurse came and said, this patient has complete heart block, what do you want to do? Came in and tried some medications, didn't work, and I said, okay, we'll set up for a temporary pacemaker. So I put the pacemaker in, it was working fine, everything went well, and the patient was fine after that, and ended up getting a permanent pacemaker later, which is what Sonny would do. But the attending came in that morning. He was an good old boy from Southern Illinois. He said, Sean, did you do that by yourself? Yes, sir. Yes, sir, I did, Dr. Blair. He said, you could have killed that patient. You didn't poke a hole in the heart. I said, well, sir, I didn't.
Good thing I didn't.
Anyhow, it was just one of those those moments. You think, oh, you're right, I could have probably poked a hole through the heart, but it was gentle.
Right.
So anyway, it's one of those stories.
Your interventional skills,
Exactly,
bless you.
exactly, that's all it is.
So I guess for me, I kind of already knew I wanted to do cardiology going into internal medicine. I did, like I said, UT Southwestern is where I did my internal medicine. And the big hospital there is Parkland Hospital, so it's a big county hospital. It's kind of like Grady in Atlanta, and it's kind of like Cook County in Chicago.
Yeah.
Kind of similar to that.
Hey.
And in that hospital institution, we actually didn't see a lot of coronary disease, believe it or not, because we were actually serving kind of the indigent healthcare population. And a lot of their disease processes are end-stage diseases of common things we see today, things that people take for granted, like taking care of their blood pressure. And so what I saw there, and which convinced me that more so that I wanted to go into cardiology, and even more so to electrophysiology, was actually, again, it's not even an instance that is with cardiology, it was actually more of a GI patient. I had a patient who was an alcoholic cirrhotic, so basically if you drink too much alcohol over a period of time, you develop liver failure, and when you develop liver failure, you also develop these things called esophageal varices and hepatic varices, and they're just basically engorged blood vessels. And this guy had come in, and he was a cirrhotic liver failure, and he was having a GI bleed, up, bottom, and top at the same time.
Wow.
So, at Parkland, when I was training, we were autonomous. We were it. The senior resident was it. And so what I did is I essentially, unfortunately, the gentleman was coding, or having code blue the whole time, for about 8 hours.
Wow.
That's what we were doing.
Wow.
And the reason why is because we were transfusing blood with trauma 1 infuser. So basically that can infuse blood in less than a second. And so we were doing that. and I had put in what we call the helmet, and it's basically something that you put in the esophagus and you actually expand it and it collapses the varices and prevents more bleeding. Had to do this all without my typing.
Wow.
And also going from the bottom too. And so this was just going on. GI said, I can't help you. And we basically, that's what I was doing. That's when I realized, I do like elective cases.
Exactly.
A little easier atmosphere. Yeah.
No, that's awesome. That's awesome. No, so I think what we really want to know, and what they're telling us, is that for all you listeners out there that truly want to go into med school and be any profession as far as a physician or PA, whatever, it is going to be challenging. It does take a lot of work. I think me coming from the athletic background, I get the team atmosphere, like having a team, a support system, that they're doing the same thing, a good environment. But at the same time, you're going to have days when you're not going to win. You're going to have days you're going to have struggles. You're going to have days when you probably doubt what you're probably doing. But you have to overcome those and believe in, if you really want to do it, you're going to fight and do whatever it takes to get it done. And for you guys, specifically, like, things have evolved so much. But the kids these days, do you believe, like the rumor is around the world that the kids now are lazy, they don't have any drive or blah, blah, blah. That's the word on the street, that's just on the street. But that they don't have drive and everyone's worried about the future. Specifically, how do you guys feel about the future of where the kids come to medicine?
I don't believe that at all. If you look back in history, every older generation calls the younger generation lazy. Turn off the music.
Yeah, when you were saying these
Get out of bed.
What are these kids?
Get out of the house.
I don't believe it at all. I think kids today have a lot more exploratory freedom. And so it allows them to actually figure out what they really want to do, what they're passionate about, before they jump into something that requires such a long commitment like medicine does. And that way you're going to get better physicians out because they're dedicated to actually doing it. So I don't believe it at all. I think every generation is going to be a little bit different. But yeah, I don't believe it at all. I think they're going to be just as successful, if not more successful, than the previous generation.
There's no way to say that better, honestly. I think perfect. Way better than I could have ever said about. I'll just add that I think there's that perception for many reasons. Number one, there is a little sense of malaise because of the way the economy and the world's gone, and to an extent, and people are particularly in their teens and 20s. But there's also information overload. I can't imagine growing up in today's era. I just can't imagine. It's kind of stunning, or at least it would be to me. I would probably be paralyzed in place and wouldn't know what to do. So for me, it was just I would sort of end up on one path, and this is all the information you had. And that's what drew me into going in the medical field in the first place. If I would have bounced around and had information about this and that and the other and all the possibilities, I don't know what I would have done. Honestly. I love what I did. I have no regrets at all. I'm certain I could have been very happy doing other things as well. But I do think that that's been a common theme. When you said kids these days, that's exactly what I thought. I thought that's what my grandpa used to say. That's what my mom used to say. And you know what? Everybody is individualistic, and we all have different degrees of motivation, or at least appearance of motivation. Because some people don't look motivated, or even they may act like they're not motivated when really they are. You can't judge that. And I've seen plenty of kids, if we'll call them that, that are truly highly motivated. They just take it differently. And I will add to that I think one thing I really respect about the so-called millennial is they have a little bit more perception of what a balanced life should be, whereas I have not had that. To this day, I still don't have it. I don't have a good balanced life. I work too much. I try to focus on my kids, and I consider myself a very good father, but I could definitely be better if I balanced and focused more on that and a little bit less on my career. So I give kudos to the younger generation for that perspective rather. So
that's a good topic. You want to add to it?
Yeah, I think it's going to be a really great evolution over the next 10 to 30 years. I think the opportunities are going to be unbelievable. And I think that the young people are looking at that, and they're going to make good on it. Now, I think the human heart always looks for some way to help other people. And, when people find that, they start to all of a sudden find their drive, their ambition, their motivation, and they bring it up. They bring it up a notch. Right now, I think there's a lot of pressure on those people because they've got so much in front of them, right? They have such a challenge. But I think people can rise up to those type of challenges. And I mean, it was the same challenge that when we did the first bypass surgery, put the first stent in, you know, those were challenges. And, you know, one guy in particular, you know, Andreas Grunzig, who was down in Argentina, he decided to blow the first balloon up in an artery of a heart, okay, and treat a heart attack, right? And what kind, and you should have seen the tools he was using. I mean, it looked like an acetylene tank over here on the side, and he had this big rail that goes up to the patient, and the balloon looks like a monster, and he puts it in a heart artery under an odd little fluoroscope. And then 10 years later, they took a picture of that same guy's artery. It looked beautiful. And that was the evolution, the invention of our field. That invention is out there for those people right now. You know, I think it's inspiring.
So there's one thing you just touched on. I would love for the QWorld to understand the involvement of work and drive and passion, right? Because you guys love treating your patients. You love making an impact on their lives, right? The quality of life, right? They came in, they couldn't do this and that, or breathe, or walk 10 yards, or even get out of bed, and now you put a stent in. Now they're out and, you know, about enjoying life. But how hard and how difficult, like truly, is it to leverage that work life and the home life? And any advice you can give?
So I could tell you from my own experiences. I grew up watching my dad. My dad was a busy cardiac surgeon in Chicago, and he would be rotating at multiple hospitals because that's what you did back then, because it's private practice. Kind of private practices are kind of going to the wayside, and more hospital-based or group practices are the norm. And so you kind of share the workload a little bit. But he was a solo practitioner in Chicago, and he wouldn't come home till 8, 9 o'clock every night. And so seeing that when you're growing up, you kind of get a trigger. My sister kind of emulates him a little bit, and she works hard hours like him. And my brother's kind of a workaholic too. But when I saw all these together, and I saw them in practice also, my brother and sisters are much older than me, I realized that they're really missing out on the finer things in life. It's a good thing to provide patient care, provide you know, all the services that we do. It's gratifying and it's self-gratifying, but at the same time, you can't be a well-rounded physician who actually respects the quality of life of a patient if you too do not have a good quality of life. So you have to make it if you want it, and that's what I do. And I do that in ways of working with efficiencies. And so when I get to work at 6:30 a.m. I know that sounds early, but I get to work at 6:30 a.m. I'm working nonstop, and I get to go home at 4 p.m. And so I see my family, I see my wife, hopefully kids soon, and you know, I enjoy my quality of life. I can't complain about it, and I'm available for my family, and that's key because in the end, we all do what we do, one, to keep us busy and to give us some self-gratification, but we all do what we want to do for the preservation of our relationships, and so that's key. And if you can't preserve your own relationships with people because you've become a workaholic, then there's a bigger issue at play, and that may affect the way you deliver care.
It's true. I mean, it leads to burnout. So it honestly felt like I was getting burnt out about a year. Actually, earlier this year, for a brief moment, because we lost a partner, it was just, we were overwhelmed with work. And it's hard to say no. I have a hard time saying no. When someone calls and says, can you do this for me? Can you do that? Can you answer this? Can you see this patient? Can you take this patient to the office? They really need to be seen. I have a very hard time saying no because I'm just not used to it, quite frankly. And so I keep saying yes, 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 yes. And at some point you realize I'm not getting home till late. I'm not seeing my kids. When I see my kids, I'm grumpy. You know, I want to get them to the bus stop in the morning and whatnot, so then I'm running late to the office because I got them to the bus stop and whatnot. And you have to some point just say no. And I'm not saying to an individual person, like a patient, I don't mean that. I mean, you just have to say no to excess work, or can you do this procedure, or this, that, and the other. You have to say no, I'm still not good at it, I'll tell you right now. So I think you have to start out that way, I would guess. And again, I can't tell you well, because at 50 years old, I'm still not good at it. You know, I'm getting better at it. I really have. I've carved out some time every week now, intentionally for that exact purpose, because two of my kids are still young, and I'm making strides to carve that out. But I think you need to start that way, understanding that you need a life too to be a better physician, to be a better person, and realizing that we are also creatures on this earth that, and if this may sort of holler out to the kids these days, but I'm a human being. I want to have a good life too, and I want to enjoy the times that have nothing to do with work. It's the actual experiences in your day-to-day world with your kids, your family, whatever, or maybe your hobby, maybe your pet, whatever floats your boat. So you have to start. I think you have to start in the beginning, which I did not do.
Well, I've raised 3 kids, and they're all out of the house. So, I mean,
Too late for you. You're
Yeah,
already,
exactly.
you might as well just work.
it's already done for me.
Right.
But if I can look back on it and say, would I have done anything different? Well, I did do some things different along the way, because it was like Steve saying, there are points in your life where you have to make accommodation, or you have to make change. So I was in a practice where I was the only cardiologist, right? That didn't last long, right? Because it was 10 o'clock at night every night, and 6 o'clock in the morning, and people calling you all the time. And I changed to then 3 people in a practice, right? It was a very busy practice. Constant demands, constantly people calling you. And there wasn't enough of 3 people to go around even, right? So I joined a bigger group. And I think that's the trend these days. Is I think they're learning from what doctors had experienced in the past. And I think actually the younger people probably understand that, because they've seen the TV, on, that's shown the people having the miserable lives and what kind of calamities they run into, and they don't want to be miserable, and they may have even had experiences in their family, a physician, and that's a good thing, right? So now I've raised 3 kids, and I really enjoyed it, and it's still going strong, right? And sure, I could look back and say, well, would I have liked to have been at one more soccer game, or at or one more piano recital? But my kids look back at our relationship and they say it was really good. Being a doctor is an honorable profession, and you give up, but what you gain in return is something that you can't replace. You just can't replace it. And so I really learned to love it.
So let's start out with basically, what are the challenges now let's start with this. Let's start, fellowship. When you come out of fellowship and graduate, you get hired. What is your recommendations for the first year guy coming in as a cardiologist or EP that they should do?
So I'm probably the most recent graduate here, but I would say the number one thing to do is not to get caught up in having to do too much. And the reason is, your first year out, most of the time in any well-established group, you're going to have a guaranteed salary. So production should not matter. What matters is the quality. Your production will develop as you develop your quality. And so it's key to have a good reputation. It's key to have good results with your procedures. As you keep doing them, your speed will increase, and eventually you'll be able to have that production volume you want. And so my advice is not to rush out there guns blazing and start trying to fix every single person out there. Do the patients you can, do a good job, build yourself a good reputation, and then move forward from there.
I was just going to add to that, I guess. Basically, it's very tempting to come out and start your practice and say, I'm ready, I'm just going to hit it, I'm going to work hard, and I'm going to do what I was trained to do. But you really want to be more thoughtful than you think you have to be, I think, in the beginning, actually. You also need to, probably at least as equally important, is to reach out to your senior partners and say, what do you think about this? Does this seem reasonable? So, I'm the director of the cath lab at my hospital, so the 2 newer partners are fantastic. They're very well trained, excellent volume before they came here. But they call me, and when they got here, I told them, I said, look, call me. Just call. And they do all the time. One of them did today, just said, hey, what do you think about this? Do you think I should do this way, or that way, the other way? And I think that's one of the best possible things you can do. Take your time, think longer than you think you need to think about something, and reach out to your more senior colleagues and ask their advice freely. I realize that sometimes there's going to be some senior partners that they're not approachable. They're not. Then don't go to them. Go to somebody else. There's usually somebody that you want to go to, that you feel comfortable going to.
I think if you look at the usual progression through a profession, it's never that you're going to pick the first job and you're going to stay there the rest of your life. right?
Right.
That's a very unusual experience, and I don't think you should be disappointed about making change, or to look at things in a different light and say, what do you need out of things? Because once you're satisfied, then your job is easier to perform. And I think Sonny's point's really good, is just take your time to kind of develop into your position. Don't get too anxious. Don't try to make a big impact, because there's no way to be bigger than you are at a third year level, right? You're just not going to do that. So you sit back and you listen and you decide, is this the right place? And is this where I want to be? And don't feel bad about making a decision that says, this isn't where I want to be, because you can change. And I think that's very important.
Yeah, I think the natural inclination, honestly, is to just jump into it and say, I want to show what I've got. I want to show that I'm good. I want to show that I'm competent. You don't need to do that. You don't have to prove anything to anybody. It's patients first. You're taking care of patients first, number one. Number two, you don't have any experience as an attending physician yet. So to go in there and feel that you have to prove something is just counterproductive. It's actually, it leads to the opposite. You actually look overconfident or cocky or arrogant or just resistant to having an open mind, which is very important in medicine, because you don't have all the answers. I guarantee it. I know for sure I don't.
Right.
And I question myself all the time. I take a pause and I reach out to my colleagues, regardless of whatever my experience is versus someone else's. Even some of the new guys that came out, I'll say, hey, what do you think about this? Does this seem reasonable? You're never going to be perfect. It's some old sort of, we'll call it an adage or cliche, if you will, but the practice of medicine is exactly that. It's practice, and we're always practicing. We're never perfecting it, but we're always aspiring to be a little better all the time. And so that's the way you do it. You don't do it within your own head. You do it with sharing minds and sharing thoughts, sharing ideas.
Now let's talk a little bit more about the details of the group. Obviously, we know that your newcomers come in, they have to take the slow pace, get things together, figure out where they're going to be and how they fit into the group, right? Not be aggressive, which everyone wants to do. Like, even when as a freshman, it all correlates. It's so funny, like sports and all that, because when it comes as a freshman, you're going to prove everything, but you realize you don't know anything. You know a lot about nothing. So you got a lot to prove and understand. So on the other side, as a tenured guy, and you're a physician, what are the different elements you have to deal with the group, and good or bad? I mean, how does that work?
Well, I think, being in it as long as I have, you learn that things don't change as fast as you think they should. All right? And small decisions are probably better in general, than big decisions. Okay, and it's the accumulation of small decisions that make big events happen. And so you have to learn how to be satisfied with small steps. And once you get the small steps and there's a little momentum, you can find big steps to take. Then that's when you have to be very careful. The big steps are the ones that lead you into the biggest mishaps if you're not careful. So one thing, if I could say, is be satisfied with the smallness. And if you can, I think you'll go a long way. If you're constantly bothered by the big picture, then you're going to make mistakes, and you have to be careful. So if I could say anything at all, that's what it would be.
I'm not tenured yet.
I got
I'm
you.
only 8 years in. But what I've learned in those 8 years is I was the guy who came out guns blazing, and I was that guy, and I learned. And if it wasn't, the one thing I learned is find your mentor. Even find your mentor when you're in as a new physician. And I found mentorship in Dr. Merritt. And I've asked him lots of questions about patients, and he's even helped me with my first complication that I ever had. And I was paralyzed, and he came in and helped me because of that, because I was just paralyzed because I had a complication. Not that I didn't know how to handle it. And so he helped me during that period of time. So it's very important to build those relationships. But as he's saying, I'm slowly learning that you can't make big changes in big groups, because groups don't move that way. Even though, don't lose heart, don't lose your vision, and never be satisfied. Because if you want your vision to happen, you have to be persistent.
Yeah, you got to look for people like Sonny that want to constantly push the envelope, right? Because I'm not the kind of guy that's going to go out and push the envelope all the time at my age. right? But I find some inspiration from someone that has some vision, and I'm willing to help them chip away at it, right?
No doubt. That's right. That's exactly.
Yeah.
Well, not to cliche too much, but one thing that someone told me about 7 or 8 years ago, which is so true, because I just as a workhorse, and people that know me know that this is very true. Extremely hard work and probably work too much, as I said earlier. But it's a marathon, it's not a sprint. You got to take your time, pace yourself, have an outside life, don't take on too much, learn to say no, and continue moving forward. You know, you got to pursue what you love and work for what you want. But to be able to stay focused, you have to have some distractions and some rest and some respite from it all as well. So, and that's important to start, as I said earlier, start at the very beginning of practice. Take your time, seek out mentorship, seek advice. Think longer than you think you need to think about something before you proceed with action, and just really pace yourself. It's important.
Yeah. So we're going to talk more about the patients. I'm sure all these patients now will be listening to the podcast and really want to know specifically. Let's start with if there's something you guys want to tell these patients, like if you're going to tell your patients to come in every day, because it's frustrating. It is. It's a big system, confusing. They're seeing you. Probably don't understand half of what you're saying most of the time,
100%, yeah.
right? And I mean, if there's something you really wanted to tell the patients, each one of you individually, because you're different structures, but let them know.
So bring questions. I definitely advocate researching what you're being sent to us for beforehand. Use Google. Create questions. Have questions. The more questions you have, the more you'll understand the concept. The one thing I'll say is if you ever find a physician that can't answer your questions, then that might not be the match for you. So have the questions, have them ready. If you're a visual learner, ask them to write it on paper. In fact, what I do in my clinic is I have a marker board and I actually draw everything out because I understand things more visually. And I think most people, when they don't understand the intricate details, they understand everything more visually. So, I don't win any awards for my cartoons, but it does help them learn and what's going on. And the number one thing I get people worried about when they come see me is things like atrial fibrillation. And the one thing I want everyone to know is that, when they come to my office, yes, there's all these things you're hearing about that, atrial fibrillation is bad, it can cause issues, it can cause harm, but it's not life-threatening. And, for atrial fibrillation, one of the things I tell my patients, and I think you should do for any disease process, is provide comfort and care, is that it's actually a natural progression of life. For example, atrial fibrillation is a natural progression of life. Larger people or in larger hearts and larger animals develop AFib at younger and younger ages. And so all we're doing is we're stopping the progression of life to help the symptoms. If these animals could talk, they could probably say, I'm having symptoms, but they can't. And so that's what we're doing. We're maintaining quality of life. And so that's the one thing I can say to my patients is anything you see me for generally doesn't have a life-threatening issue with it.
I got you. So since I was a medical rep and I can ask a little bit more detailed questions, I'm going to dig in with Sonny and then I'm going to dive in with the other guys on a separate part. But Sonny is an electrophysiologist, so all the things he's going to deal with are going to be more of arrhythmias. So there's different types of arrhythmias. You just talked about atrial fibrillation. We're going to talk about ventricular tachycardias, and we're going to talk about ejection fraction. So let them know, I know I've heard this from just the pacing world coming back, that the patients come in is like, my ejection fraction is this. What does that specifically mean, and how does that affect them in their day-to-day life?
So when you say ejection fraction, and this is actually the discussion I have with my patients, it's a fraction of something. You can't take that number alone and say, this is how you're doing, this is how you're going to do. It's false. It's actually what you're capable of doing and what you're capable of doing even more with the help of medical therapy that's started and things like that. Your exercise tolerance is much more important than that number. We're taught in medical school not to focus on the numbers, and so I want patients to understand that the number doesn't mean anything to them. And what it means to us in the EP world is, so if you imagine the heart as a jar, right? The jar contains a finite amount of material we can put in it. And then the ejection fraction is a crude estimate of actually how your heart functions, the strength of the heart. Okay? But it's a fraction of something. So you can't take the number alone and call it good. You actually have to know the size of the container. And so if you have a normal heart that is capable of holding 100 of blood, for example, and your ejection fraction is 50%, there's no such thing as 100%. 50% or greater is considered normal. If you put 100 of in there, 50 comes out, right? Let's say you have a sick heart that had a bunch of heart attacks or has some viral illnesses, and let's say that contractility or ejection fraction number is 25%. Okay, well, in that sudden change, your heart hasn't any time to change shape. So what happens is you still can only put 100 in there, but 25 comes out, right? So when that happens, from a sick to a healthy state, you've lost half your blood volume to the rest of your body. You're going to feel lousy. Over a period of time, what your heart does, it takes whatever tissue that's not working properly or contracting right and converts it to scar tissue. And when it does, it makes the heart bigger. So your container is bigger. So now you can hold more. So your heart function may go up or may go down, but the important thing is it can hold more. So you put 200 in there, 200 times 25% is now 50 again. You're putting out exactly what you're putting out when you had a healthy heart. So that's what we call compensated heart failure. So that number isn't the end-all be-all of how you're doing. Okay, but how it applies to my clinic is, from the reasons I explained, the lower that number is, the more scar tissue you have. The more scar tissue you have, that's the higher risk you have for those malignant arrhythmias like ventricular tachycardia or ventricular fibrillation. And that's what we put defibrillators in for. So that's kind of explaining my view of ejection fraction.
So I'm gonna go one more question with Sonny. So what is sudden cardiac arrest? And then I'm gonna talk to you guys about what a heart attack is. So different. But everyone says that they're both the same. They're not the same in the public. They're different. So what are most of the people dying with day to day? The biggest thing, the number one thing that people die of each year in numbers, out of all the different medical issues you could have outside of cancer or anything, what are they dying of?
It's sudden cardiac arrest. Yes. So sudden cardiac arrest is not a heart attack. It's like comparing apples and oranges. Now, so what sudden cardiac arrest is particularly, it's two different rhythms. It's ventricular tachycardia and ventricular fibrillation. Those are two malignant or abnormal rhythms that come from the two bottom ribs of your heart, called the right ventricle and the left ventricle. And so what happens is your heart pumps so fast, because it's an arrhythmia that's fast, that it can't pump blood out. So it in fact arrests in the term that it can't pump any blood out. It's not stopping, it can't pump blood out. Okay.
Yeah.
So that's what cardiac arrest is, and that's what defibrillators are for.
Thank you. I appreciate that. So now to the cardiologists, we call them the plumbers. So talk to us a little bit about your world and what you see. Obviously, we talked about myocardial infarctions earlier, which are sudden, but the different scopes of what you're dealing with. Not only that, from even your valve even treatment and all that. Just talk a little bit about what you guys do specifically. And you can split it back and forth, whatever. Yeah.
Well, heart attack, when we say that, typically what we mean is an artery that is either nearly occluded or occluded, and it's suddenly occluded. And by occluded, we just mean the flow is restricted or stopped. If it's completely occluded, the flow is completely stopped, so there's no blood getting to a portion of the heart muscle, that pump that Sonny was talking about. So now part of that pump doesn't function. The muscle doesn't squeeze, and therefore you've suddenly lost a portion of that functional heart tissue. And it's experienced usually by pain for about 70% of people in the chest. And some people it's just shortness of breath, or pain in the neck, or the jaw, the arm, the shoulder, or the back. And that's reflecting that loss of blood flow to that part of the heart. If it's complete and sudden, that's a massive heart attack, as some people might say. You might call it a small heart attack if it's incomplete, meaning there's some flow getting past that blockage or that clot, but it's not enough to sustain the normal function. So when that happens and people come to us, we take them to what we call a cath lab, which is like an OR for cardiologists, and we then go up, usually to the leg, I shouldn't say usually, sometimes to the leg, sometimes to the wrist, and go to the heart arteries, and we find that blockage by shooting dye and using x-rays, and then we typically put a wire in it, open it up with a balloon, and restore blood flow, which then relieves the pain and potentially restores function if it occurs quickly enough. The problem is, people are afraid to call 911 for many reasons. First of all, it could be denial. It could be afraid of the bill that they're going to get from the ambulance or the doctor, or they think it's heartburn or whatever, or they think they have the flu. The problem with that is there's loss of blood flow to the heart muscle. Those cells start dying off, and if enough die off, then you end up with a situation where Sonny was talking about, where you have the scar tissue where that muscle is not pumping. So now you're relying on the rest of the heart muscle that's still working normally or near normally, to pick up the slack, so to speak. So that's a heart attack, and the important part about heart attacks is getting attention immediately, because the longer the time, the more minutes or hours that go by, the less likely you're going to recover any of those cells, that muscle tissue, to restore normal or near normal function. So, and since we're talking about that, I'll just say that you always hear about the golden hour in trauma and the heart, and it's very applicable. If you lose complete blood flow to the heart muscle for an hour, you've lost a lot of potential for recovery, certainly full recovery. And as the hours go on, you lose any possibility of recovering that muscle at all. So it's very important. So when people experience this discomfort, it's not usually a pain, some people it is, but mostly it's a pressure or heaviness or tightness, and oftentimes it's in the chest. That's often a sign of a heart attack. You should take it seriously and call 911, not drive to the ER to not. That's how important it is. It needs to be taken care of right away.
So, Dr. Merritt, when we go, I want you to go through so when you see patients in clinic, where are they coming from, and then what are you telling your patients in clinic as far as how to ease and educate them to make their experience better, or what are you doing in your practice to make them feel better about what their expectations are?
So being an interventional cardiologist, I usually see a lot of patients with heart attacks, right? So I depend on Sonny, I depend on my partners to take care of those patients either in the acute setting or in what we call the chronic setting, right? So in the chronic setting, or after they've had a heart attack or they have established heart disease, then we manage their cardiovascular risk factors. We want to treat their cholesterol, their hypertension, get their level of activity up, discontinue smoking, and all those things that we've all heard about, right? But I think a lot of the time is spent with education. In the clinic, it's an educational environment. I think if people get the wrong impression that the clinic is a place where you just go get the check and you're okay, right? A lot of patients leave and they say, yeah, my doc told me I was okay, right? Well, that doesn't mean that they're focusing on their risk factors. That doesn't mean that they're focusing their attention on symptoms. So I try to educate the patients in multiple ways. The nurse tries, our office staff tries. We have educational formats in the setting of a electronic board that reels through a bunch of different disorders that they read while they're in the waiting room, right? But when I see them, I want to educate them, and I usually educate them first about acute settings, right? I don't want them to miss the idea that they could have an unstable syndrome, right? Because most of the time in the clinic, it's a stable environment. You talk to them about chest pain or exertional symptoms, and they may or may not have them. But what you really want to educate them on is what Steve was talking about. If they start to have severe symptoms, we want them to present early, because the average time to presentation is 3 hours or more, right? From the time of onset of bad symptoms, it takes them at least 3 hours to get to us. We'd like to reduce that. 1 hour is the golden hour. We would like to see them within an hour. Now, we know they can't always make that. Maybe they're a long ways away, but we still want to educate them that time is of the essence. If they notice a change in their symptoms, they should call us. And so I educate them in that regard. Then I educate them about the risk factors. Why is it important that hypertension is controlled? Maybe why is it important that their LDL reach a specific goal? And I always like to tell them that be patient with the doctor, right? You want to allow the doctor to take time over years to help them prevent their next event. It's not one doctor's office visit, it's several over time. So, if we can do that, then we've made a difference. But not to just come in and say, well, you're looking fine and you're doing fine, see you at your next heart attack.
Pat him on the back,
That's not what we want to do.
I think it's important too to contract the patients for their care. This is their body, this is their life. We see for 30 minutes, if things are stable, 30 minutes a year at the most. I mean, honestly. And so I try to reinforce my patients, look, I'm just seeing you for a moment in time. I'm reminding you things that you should do, and you need to be involved in this. This isn't me just coming in and fixing your problems and tweaking your medicines and making you better. It's not going to happen. You're involved in this too. There's so many things that are non-medicinal, and I very much believe in medications that I prescribe strongly. They're excellent medications, and they make a massive difference in the potential for reducing symptoms and improving longevity and independence and being able to function independently and do the things they want to do.
Right.
But they have to contract as well for that, 11 months and 29 days I'm not seeing them,
Right.
to do things, to shift their life, their lifestyle in a way that makes it a little better. I never ask them to say, you need to stop smoking today, you need to eat 2,000 milligrams of sodium a day or less, you need to quit eating all that fat, you need this. I said, make a shift. It's like changing lanes in the car, getting off the highway. You're not like jumping over from Highway 44 to Highway 70.
Yeah.
You don't have a helicopter to do that with your life. Do the same with your lifestyle. Little changes, but make them happen over time. Commit to that, because that's really just as important as the medications that we're giving the patients. So I asked them to sort of contract with me to make changes, to do their part and make those changes. Take the medications, but also make the changes.
So
go ahead.
I was going to talk a little bit about the interaction between the electrophysiologist and the interventional cardiologist. So many people do have a heart attack and it leads to sudden death, right?
Mm-hmm.
Well, that's that arrhythmic point. That's why we tell people present early, because the likelihood of a sudden arrhythmia grows as the time the heart attack progresses. Now, some people can have a sudden arrhythmic event very early in a heart attack, right? First 10, 15 minutes, your norepinephrine levels go way up, your anxiety level goes way up. The whole nervous state of having a heart attack is very influential on your heart rhythm.
Mm-hmm.
At that time, it's really important to make the right decision. The family members need to make a right decision. They need to call 911 as soon as they can. All family members should be able to perform CPR. Remember, it's just fast and hard on the chest anymore.
Yep.
It's not breaths, it's
Yeah,
not
exactly.
number of breaths, it's not any of that. It's just the drum beat, right?
Yep.
You hear it on the radio, the drum beat.
Exactly.
Do the drum beat on the chest. Middle of the chest, press hard and fast until help arrives. That can save a life.
That's huge. I was going to actually when you were starting to talk, I was thinking about that. And if everybody knew just the basics of CPR, and you hit it perfectly, then a lot of lives would be saved. Disability would be reduced as well, because part of it's that people get, the EMS may arrive, so the 911 people come, the ambulance people. If 5 or 6 minutes have passed and there's been no CPR, people don't typically survive that with any sort of at least functional capacity. Severe brain injury, things like that. But if there's even modicum of decent CPR, pressing the chest like the drum beat, hard and fast, nice and deep, it's okay if you hear some popping and cracking, then many lives be saved and disability be diminished a lot. Very important.
And we can get you to the electrophysiologist.
That's right.
Exactly right. So for those patients coming in, and as you said, they come in, their MI, what is the status? So I'm sure some are confused, like, you may say, you may need a defibrillator later after they get a stent. What is it? Why is that? What's the term? How is it just correlated to before you can send them to, Dr. Parvathanehi and all that? How does that work? So they understand, like, it's not you just saying it is the way it is.
Well, there's guidelines that we use,
Yes,
and
sir.
guidelines are just that.
Yep.
They are guidelines. They're not set in stone. They're not law,
Mhm.
but they're guidelines. But the general guidelines say that if you have a heart attack that injures your heart significantly, to reduce your ejection fraction less than 35% in general,
Right.
30 to 35%, then the follow-up should be within 40 days and a reassessment of your ejection fraction after you've had medical therapy. Okay, that's for an acute heart attack. Now there's different guidelines for just the diagnosis of heart failure for other causes. Okay, that's a longer term treatment period before you would get to Dr. Parvathanehi. But if you had a heart attack today and it's substantially reduced your ejection fraction, we would treat the culprit artery, open it and fix it, put you on appropriate medications, and in 40 days repeat your echocardiogram or some type of functional analysis of your heart function. And if we felt like your heart was still compromised, it would be risk then associated with that, the risk of sudden arrest. And that at that point we'd refer to Dr. Parvathanehi and say, hey, what do you think? Remember, the guidelines are this. It doesn't fit for every patient. That doesn't mean you're getting a defibrillator. That means that you're getting an evaluation for guideline-directed therapy.
And so, basically, the guidelines suggest after an acute heart attack, If there's no intervention, you wait 40 days to get reassessment, and if there's no improvement in the ejection fraction, they suggest you can proceed with putting in a defibrillator. However, if there is intervention, you have to wait 90 days with optical medical therapy, meaning you got to take all your medicines, you got to take a beta blocker, you got to take an aspirin, you got to take a statin, you got to take an ACE inhibitor, and as long as you can tolerate all of them, take them faithfully, and then at the end of 90 days, if there's still no recovery in the ejection fraction, then we proceed in doing that defibrillator for primary prevention.
So I'm going to switch this over to another topic, and this is for the athletes out there because it's a whole nother level, and this is also a passion of mine. But there's a lot of athletes out there that will go through a practice that will be hot in the summer, or they'll get stressed and run and blah blah, and next thing you know they fall short. We're talking about hypertrophic cardiomyopathies, and I would love Sonny to talk a little bit about that and what that means within large hearts and how it works and why that happens to these athletes and what maybe they can do to hopefully prevent that, if anything.
So hypertrophic cardiomyopathy is a genetic disorder that is autosomal dominant. And what does that mean? It's only one parent needs to have it to transmit it to the child. And so if a parent is diagnosed with hypertrophic cardiomyopathy, all their children should be screened with at least an EKG with their pediatrician, and then followed through. And we even offer genetic testing also for that too, especially with student athletes, because you don't want that situation to happen. In general, with hypertrophic cardiomyopathy, the younger you present with it, the higher the risk you are for sudden cardiac arrest. So, say you present with it when you're 5 versus someone who presents with it when you're 60. The person who's 5 is going to have a higher risk profile than the one that's 60. And so that's another one of those conditions that we start getting worried about. You don't want to do all the intensive exercise, the contact sports, and things like that, because what happens with the physiology of that is the more exercise you do, it actually has a kind of a reverse effect, meaning that your blood flow can get trapped in your heart and not leave your heart and induce these arrhythmias too. So that's where the obstructive cardiomyopathy part comes in. But in general, I think it's much more recognized today than it has been in the past. And so I think we're doing a better job overall. Could we be better? Yes, we could be better. But it takes awareness. And it takes awareness as with your children. And if you have it, to screen your children.
It is the most common cause of sudden cardiac arrest in the young people, right? Especially athletes. So it's very important, like Sonny said, if you have a primary relative that has that disorder, you need to be screened. And early echocardiographic assessment is probably essential to make sure that you don't have a young onset pattern, because that confers more risk. Not everybody, even with hypertrophic cardiomyopathy, will have an adverse outcome. But there are certain parameters that we recognize as high risk, right? So that's up to the cardiologist and the electrophysiologist to understand what those high-risk factors are, so we can provide counseling and treatment when necessary.
And that's exactly right. Not every single person who has hypertrophic cardiomyopathy will have a sudden cardiac arrest. There is risk profiles that come with it, and in fact, the vast majority don't have anything. In fact, the vast majority actually get discovered in their 60s or 70s as related to some other heart issue they're feeling. And so it's, in general, overall, it doesn't always result in adverse outcomes like he says. But if you do have that primary person who has it, it is incumbent on everyone to get screened.
So I want to touch on this real quick. The majority of the people that you're seeing, we all can assume are the baby boomers, right? Right, we can assume.
Right
yeah. So, is there anything you guys, as far as this way what you're working in, the environment and the stresses and everything you're dealing with, and the baby boomers, is there anything that you can say toward the baby boomers as far as just advice or what?
Well, I think, the baby boomers are pretty much described population right now. The millennials probably have a little bit more to be concerned about because they're getting I don't know exactly what their age range is right now, but there's probably something in between the millennials and the baby boomers, and those are the people that we're kind of starting to see.
Generation X, that's me.
Yeah, there you go.
Exactly.
See, and we're starting to see that population, but the risk factors hold true, right? Pay attention to the risk factors. If you're smoking, you're going to get heart disease. You're going to get lung disease. You're going to get vascular disease. And that's a very difficult thing to deal with as you age. And those people die younger and they have more problems earlier. So, I think the education is pretty much listen to what your parents are saying about those things and look at maybe the population of the baby boomers to show you what you shouldn't be doing. Because there's a ton of baby boomers out there. They're perfect examples, right? But I'm hoping public health grows to the point to where we, start to understand risks up front. We didn't learn too well from cigarette smoking, right? There was a lot of deception. There was a lot of misunderstanding, right? And I think that holds true today. There's probably a lot of misconceptions and misunderstanding about some of the habits that could be developing amongst those populations now. E-cigarettes is,
Oh my God.
That's or the vapes and things like that, and marijuana. Those things, we don't understand a lot about the long-term impacts like we do cigarettes, because cigarettes, we had 60 years of experience, right? Maybe more. Right? So I would just say be careful.
Speaking of cigarettes, I still remember, and not remember because I wasn't around, but you still see pictures on the internet about, in the 60s and the 50s, and there's things saying where doctors are smoking cigarettes and say, take a cig, it'll keep you away.
Oh, really?
Yeah, stuff like
Wow.
that. Yeah, and stuff like that, and it's kind of a segue because we don't know. We have that long, rich history of tobacco, but we don't know what the long-term effects are going to be for other things, including marijuana. And bringing up deception and things like that, I think we're having the same lobbying deception we have now for marijuana, like we have with cigarettes. I mean, I'll tell you one thing is marijuana. People who smoke marijuana, oftentimes they don't get the pure thing. No. That's one thing. And two, it does prolong the QT, which is your recharge time and your EKG, and you can develop secondary episodes of cardiac arrest from it.
I'll just compliment what I was saying, basically, that so for the true baby boomers, it's never too late to change. It just is not. And so if you're smoking, I've actually had patients say this before, I've been smoking 50 years, I'm not quitting now. Why? Well, what does it matter now? It does matter, because as soon as you quit smoking, within days, your heart attack risk goes down, your stroke risk goes down, the accumulation of, if you haven't had a heart attack yet, great, you're reducing your odds, but your odds are triple at least. I like to say more because I think it is, of having a heart attack if you smoke. If you quit smoking and you used to smoke, your odds are still up, but they go down. They bring it down a notch to 2 times instead of 3 to 4 times.
That's why your surgeon tells you that you should stop smoking at least a week before your surgery.
Yeah.
Why is that? It's because your outcomes are better. And they're right. Right? So
One of the funny things I sometimes tell my patients when I establish a relationship with them is that, when about smoking cigarettes, you don't see a squirrel going out there picking up a stick and lighting it on fire. Right. You don't see that happening. You don't see animals running into a fire. So why are we putting it in our mouth?
it's a good point, Sonny. I tell my patients, anything that burns that you inhale damages your lungs.
Yeah, exactly right.
Anything that you burn that you inhale damages your lungs. And your lungs have the largest surface area of any organ in your body, right? It's huge surface area. It's like a football field in there. And and that is exposing all that tissue to those toxins. So be careful with your lungs.
So I want to empower everyone out there. You have family members. I mean, this is not uncommon. I mean, the rate of sudden cardiac arrest and even heart attacks is so high in the United States. But my dad passed away personally at a young age. He was in his early 60s and heart failure, smoked, he was in the military, and said the same thing to me that most probably your patients say is like, why change now type mentality. I lived my life, had a good life. So I respected that, although I did encourage him to stop. And yeah, he passed away in his early 60s. So if you think you guys can do is just take heed of what we're saying today. Social media wise though, what I want to impactfully talk about is how do we, so here's what we're finding now. One, it's everyone's information now. They don't have the patience to go see you and go through this recommendation and blah, blah, blah. And then when they go there, if they don't feel like it's right, or they got someone that came from out of town, they don't know anything, they're going specifically to blogs on websites. They're going specifically to these apps, you know, and they're getting information from there. Our studies are showing that almost 54% of the women, which are mostly women, are getting this, which ends up being about 40 million people in the United States, are all using apps for their second information, and they're more leaning toward the second than the first when they're seeing you in the office. And I'm just trying to get an idea, how do you guys see this going? Because it's definitely going to be an issue that we need to get the content the right way to the patients, not from these side and third parties and people that had bad outcomes or whatever. We want to give them the right information from you, because you guys are the ones that can drive it, right? But how do we do that in the right way? And is that important? Do you guys think that is important?
So I would say that it is important, and it's important to have a partnership with social media because it is good to have information. But what we see on social media, we have to remember, is a generalization. What becomes important is seeing your physician so you can get tailored therapy for you. And so you don't want to be treated necessarily the same as someone else who is miles and miles away, whereas you can get your own tailored therapy through your physician.
I would disagree with that. I probably won't add much to that, except just be cautious, because with apps and with social media and with information on the internet and whatnot, besides the fact that you're not getting tailored therapy specific towards not just your needs but also your own personal nuances. Not everybody has the same values from one to the next, and so that's not taken into account. But the other thing is you get false information on the internet sometimes too, and we all know that intuitively, but just you need to remind yourself that when you're going to that information, you may be getting generically correct information with some nuances that are incorrect and specifically maybe bad for you individually. So.
Yeah, I think you need a tailored approach, right? Not everybody's going to be right for every person, right? I think that it's very important that if you have a process that's going on, you need to learn about it as much as you can, and then you have to ask a professional, right? And you want to ask a professional in the right field, and then you need to research your professional and see if they have, adequate education. Make sure that they're with an institution that evaluates their educational aptitude and also keeps them up to date. We all belong to institutions that watch us a lot, right? And, it's not like a monitored environment that we're in, but they set standards, and they use standards from, associations that monitor us, right? We've all taken board examinations, and we're highly educated in our field, and we've had a ton of experience. That doesn't mean I'm the right doctor for you, but you'll want to generally pick from that source, right? So I think that you won't go wrong if you decide that you're going to specify your specialization, I guess. So anyway.
Well, you guys, any last words or anything you want to say before we close? But for the most part, we're finishing this. Anything?
Thanks.
Q-Life.
You like
Q-Life.
So I want to thank everyone for coming in. This is QWorld, and I want to thank everyone to come out and listening to this and visit. I hope we gave you great information, something that added to your life, and that's what we're going to continue to do, is put out quality content. Also, I want to thank these gentlemen because they've had so much going on in their lives, and to take a couple hours out to hang out with us, to talk to you, to give you real information. If there's anything you need or any questions you have, please email me or text me, and I'll make sure I get the right information to you. But we want to make a change in the way things are going as far as social media and information is getting to you, and I hope this helps. And on 1, 2, 3, we're going to say QWorld. 1, 2, 3, QWorld.
QWorld.
And
Thanks,
you guys
Marlin.
have a good evening. Take care. No, thank you.